And action! Robert had a question on LDN, or low-dose naltrexone. And I wanted to do this as a tutorial, but because of the volume of information and the benefits we've found anecdotally, it's probably going to be broken down into several different tutorials or questions. So the idea with low-dose naltrexone, it has been used, it's a medicine that is used to reverse the bad side effects from morphine or morphine derivatives. I used it once in the emergency room when I had a patient that had severe back pain, 10 out of 10, couldn't breathe, couldn't focus, and we had a kidney stone that we diagnosed, but we wanted to bring down her pain immediately. And we can do that with oral medicines, but it takes a couple hours, so we did it with a shot. The shot is Dilaudid, and Dilaudid works kind of like morphine, it's a cousin, but it worked to reduce her 10 out of 10 pain down to about 6, which was really good. But unfortunately, one of the side effects of those medicines is also low blood pressure and low heart rate, sometimes fainting. So those are bad side effects. What we can do in an emergency situation is to reverse the effects immediately. We give Narcan. That's high-dose naltrexone. And Narcan immediately made her symptoms go away because it blocked all the receptors. And her blood pressure came up, which was good, but her pain came back. So that's the side effect. So what happens with these receptors? This is my son's science project, and this is a cell, that's a nucleus, that's the manager of the factory, and this is the assembly line, the cell cytoplasm. When a cell like this works in the body, it has an outer cell membrane, and the outer cell membrane keeps everything intact, but it also allows communication to the bloodstream. And when say a morphine molecules in the bloodstream, it connects to the outer cell membrane and it affects the way the manager gives orders and the way the assembly line makes things. So morphine, when you stimulate the cells, there's certain receptors on certain cells throughout the body, kappa, delta, mu, and something called OGF, and all those receptors have been studied. And this is the cool thing, is because of the work of several doctors, they've published nice work on what happens, specifically with Crohn's disease, a little bit less with multiple sclerosis, a little bit less information as far as randomized controlled trials with fibromyalgia. But we found that usually if the morphine binds to a receptor on the cell and affects the way the cell works, it can make suffering go away. That's for people with chronic pain, cancer. But the problem is, sometimes when you have too much morphine or opiates, it will cause the low blood pressure. If you have too much stimulation of morphine, then you don't want to be having the side effects. Now the opposite happens when you're in chronic pain. If you have chronic pain or autoimmune disease, the theory is that the receptors are less, and you don't have any endogenous opioids. We can make our own enkephalin and endorphin. And if you watch my video, DrRic tutorial, Endorphin High, I talk about how exercise brings on endorphin response. So we make our own, but sometimes you need a more than usual amount. That's where the morphine shots come in handy. But in the case of chronic disease, when we suffer all the time, endorphin production decreases. We found that people with Hashimoto's, multiple sclerosis, Crohn's disease, even cancers, have low levels of endorphin. That's what Bihari found in the 80s with his studies using low-dose naltrexone and AIDS patients. He found that it improved their cells. And if you know what AIDS is about, AIDS is when you have a decrease in the amount of, well, there's a balance between suppressor T cells and helper T cells. The T cells are the lymph tissues or the white blood cells that float around to fight infection. Unfortunately, when they do the opposite, they actually kill you because they, instead of attacking bacteria and viruses, they attack the body. Not good. So when you have decreased endorphins that are being made, you feel bad, you have pain. But what you can do with naltrexone is overnight, if you take doses between 1.5 to 4.5 at a short burst, you block all the receptors to all the cells in the body as far as endorphins. Now, you're right, the amount of endorphins already decreased, so you're suffering and you're in pain. But if you block them and then you suddenly release them, there's a rebound effect that when you're being blocked with that low-dose naltrexone, that fraction of the dose of the high-dose naltrexone, you will actually tell the brain, I need more morphine, I need more opioids. You don't get morphine, but the body can produce those opioids without having you exercise, like in my video. And usually when they get produced over the course of 10 to 16 hours, your low-dose naltrexone will go away, it'll be metabolized, and suddenly you have this wave of high endorphin response that'll start to stimulate every cell again. If every cell starts to get more endorphin created by the body because of that temporary block by the naltrexone. And then during the block 2, the cells of the body also make more receptors. So number one, you have more receptors on each cell to take in and get stimulated by your body's endorphins. And then you have this whole wave of endorphins in the bloodstream that also connect with the receptors. Suddenly you have a positive effect. And again, if you exercise, you'll know the positive effect. You watch my video and you'll understand how exercisers will usually have less infection. Exercisers will have better outlook. They'll have better sleep, better sex. I think it's because of the endorphin response that they have. And the endorphin response, in theory, is supposed to affect the way all the cells in the body work. If the cells in the body are being given and pampered with messages to help this manager, the DNA, the nucleus, and help the cytoplasm or the assembly lines produce what they have to produce, cells work better. It's almost like eating a whole food plant-based diet, meditating, exercising all the time. Those are the benefits that I believe give us longevity. Now, if you think about that theory of how you bind to a receptor and it changes the function of all the cells, then again, the data says that if you use the same concept to decrease inflammation in the brain, those are microglia cells that take care of inflammation in the brain, decrease the macrophages in the gut, those are the cells that attack and cause problems and inflammation to Crohn's disease patients or ulcerative colitis. If you reverse the inflammation, you'll have less suffering. As far as the microglia cells, that's where the theory is that it impresses or changes around the suffering, inflammation, and brain fog of fibromyalgia or multiple sclerosis. And again, in Crohn's disease or ulcerative colitis, where the inflammation decreases and the barrier in the gut becomes strong again, so you don't have any more leaky gut issues and allergies. So those are all the theories. Unfortunately, short of the studies by Jill Smith with regards to Crohn's disease and Bihari with AIDS patients, all the other things I mentioned, rheumatoid arthritis also there, but multiple sclerosis, fibromyalgia, chronic pain syndrome, chronic fatigue syndrome, the data is small. We always like to go by randomized controlled, double crossover studies to decide whether a medicine is good or not. The medicine has to show some therapy and has to show low side effects. And I think low-dose naltrexone is limited with the data that's out there because randomized control double-blind crossover studies are very expensive, several $1 million to do a study. And if it's not being backed up by a big pharmaceutical company, who's going to put that data out or the money to fund the study? Nobody. That's why most of the studies that you'll see out there are usually underpowered, small subject content, or at least the amount of patients being studied is very small. So I think there are studies that are out there. There are anecdotes from other doctors using low-dose naltrexone with those diseases I mentioned that have been great. So the amount of data is limited, the anecdote and the stories are high, but the side effects are low. Biggest side effects for low-dose naltrexone would be that you might have a problem with profound dreams and maybe a little insomnia for the first couple weeks, but that's where you can adjust the dose, and rarely headaches, and that's about it. It's even used by, with again, small subset of patients in pregnancy with no bad outcome. So I think that considering the benefits and the risks, it is worth it to try low-dose naltrexone, especially if you're at a level where your autoimmune disease is not responding to massive medicines and you're still suffering. So as far as how long it takes, it can be a couple months. You have to be patient. As far as how high and how fast to ramp up, there's different protocols, but again, there are loose protocols. They haven't been medically accepted just yet. It's all different doctors using it for their patient population. I also prescribe medical marijuana, and the information is also out there and evolving about the use of medical marijuana, CBD, THC to affect the cells again, affect the cells and the way they work to either protect the body or do their job. And I think it also is based on the same thing. You have this stimulation of a cell to work better with either cannabinoids or LDN. And I think they both work the same way. The thing with cannabinoids is, at least in the state of Illinois, you pay for your own license or your certification, and you pay for the cannabinoids every month. Could be several hundred. LDN is very cheap. Usually the price of LDN, you can get it at, this is a nice book for if you want to review any authors, nice easy read for laymen or medical professionals. But LDN, if you get it from a compounding pharmacist, about 30 to 40 bucks a month, which is much cheaper than medical marijuana. So I think both can help. This is an affordable way. And if you can find a practitioner that's willing to try it, it's just called an off-label use. Again, it's a medically approved prescription drug, high dose naltrexone, but it can be off-label use at low dose depending on what the doctor can find and help you with. I'd always say it's not just the LDN. You can't just stop all your cancer medicines, and that's another thing it's good for, cancer treatment. I think it's an accelerant, it is an adjuvant, but it's not a protocol yet. So you can't just stop your cancer medicines, you can't just stop your hashimoto's thyroid medicines, you can't just stop your multiple sclerosis medicines. But I think that if you're hitting the wall and you're not getting any good results and it's not affordable with standard treatment, it might be a good alternative. So Robert, hopefully this gives you a little idea about maybe considering LDN. Remember, even if you do LDN, you still have to maintain an anti-inflammatory diet, you still have to exercise, you still have to have some form of mindful practice. A lot of the autoimmune diseases are spurred on by gut. I mentioned about Crohn's and ulcerative colitis. The GAPS is just one autoimmune diet and practice that you can get into. There's some people that follow paleo, there's some people that do ketogenic, there's some people that do paleo autoimmune dieting. Bottom line is, even if you take the chance of trying LDN short term, you still have to practice those three things and maximize on your health with healthy lifestyle.